if you want to join in, so there's a Slido there, a QR code or the Slido code there. If you want to quickly pop that into your phone, I will go back to the Slido thing. So I'm going to be talking about management of devastating brain injury or perceived devastating brain injury patient. I'm going to be going through our national guidelines, intensive care guidelines as basis for this. So if you've got questions as we go along, by all means put them into the chat. Teams is always a bit complicated, so putting your hand up doesn't always get that answered. But if you've got questions, save them for the end or pop them into the chat, and I'm happy to answer them. I'll start by saying, as I mentioned, I'm one of the clinical leads for organ donation. One of my roles is to ensure that any patients that are dying gets referred for assessment for suitability for donation. The reason this sort of ties in is that the brain injured patient is often one who's able to donate their organs at the end of their life and then go on to save others. It's really important that we give those patients the opportunity to donate. There's a massive waiting list for donation, for organ donation. I mean, for kidneys, which is obviously I'm sort of a nephrologist as well as an intensivist, and the waiting list between 3 and 5 years, and it's getting bigger. So really need to kind of make sure that patients that want to donate are able to donate if they're in a position to do that, really. So these guidelines are used for any patient with a primary neurological diagnosis, most commonly those with traumatic brain injury, so subarachnoid hemorrhage, intracerebral hemorrhage, stroke, hypoxic brain injury, things like that. So obviously quite applicable to you guys at the Royal with kind of the trauma, brain injuries and bleeds coming your way, but equally us at the Glenfield with the hypoxic brain injuries and those sort of patients as well. So I'll start with a bit of a quick quiz about donation. So I just wanted to have a quick look at these and tell me which of these ventilated patients would be a potential donor. So the Slido should be active. You can click more than one. Someone click any and just let me know that it's working. So if the QR code's not working, you can just type in Slido and just put in that number 5451919, and that'll take you there as well. So which of these patients are potential donors? And people are voting. Very excited to see. Good. Okay, so I've got no idea how many of you are in the audience, but we've got a lot of votes in now. So going through the votes, the vast majority of you have said that the 40-year-old with ARDS on ECMO is a candidate, and that's absolutely correct. And well, the long and the short of it is every one of these patients is a potential organ donor. We've had patients, these sort of patients, missed as potential donors over the years, so it's really important that we don't miss them. Being on ECMO, even with either organ failure or potentially brain dead with neurological death on ECMO, still a candidate for donation. Being 82 years old, again, still a candidate, still donate. Having hepatitis C, we're donating transplanting patients with hepatitis C nowadays with appropriate treatment. So essentially, all of these are potential donors. And the point I really want to make is don't make things complicated for yourselves. If you've got a patient who's dying or you think has died, is already sort of brain dead on a ventilator, don't try and think, oh, are they going to be screened out? Oh, they've had this in the past? Are they? Just pick up the phone, make your lives easy, pick up the phone, speak to the SNODs and let them do the hard work. They're trained for this. This is what they do day in, day out. They screen these patients out. Let them do it. So I'm a big believer in making it easy to do the right thing. And all I would say is if you've got someone on a ventilator who's dying, pick up the phone to the SNOD early on, make an early referral and let the SNODs work out if this patient's for them or whether they'll screen them out, really. So with that in mind, I'll go on to these brain injury guidelines, and this session will be based around these guidelines, and these are the guidelines that I'm talking about. They're from 2018, so they're a bit old now with a few updates recently. For anyone sort of approaching their anaesthetic exams, this is useful, and by all means, I'd stress have a look through them, have a read through them to give you a bit of an idea. They're not that long. So I just want you to think you're called to ED. There's a patient that's collapsed at home, complaint sudden onset headache followed by a collapse. The ambulance first responders, they've arrived. They've got a low GCS of 4, eyes 1, voice 1, EMS 2. intubated at the scene, they brought them to ED. And now you're called down as the ITU registrar, ITU trainee to come down and kind of take them on next. So as you get there, the patient's just coming out the other side of the CT scanner, and that's the CT head. So this is obviously showing a large intracerebral bleed. So obvious thing, you know, you stabilize them, you pick up the phone, you ring your local neuro centre. Hang on, my small nearly 4-year-old guest has appeared to join in. You ring your local neuro centre and they say there's no neurosurgical intervention. What do you want to do next? These are your options. And again, he's just been wrestled out of the room. So again, so these are your options. QR code is active. Hang on. Have a little think whilst I wrestle with the child. Cool. All right.
Ricky, can I just make a little point?
Yes, please. Yeah.
All I would say is, while I'm absolutely in agreement with what you're saying about anybody can refer any patient, we should be doing it early and thinking about it early. I would just ask that you check with the consultant who is looking after that patient on intensive care before you do that, just because we have had some issues around discussions, particularly overnight, and particularly related with talking to relatives about organ donation without the consultant knowing. So it's just worthwhile just mentioning it at least, and we will, as far as we can, we will support that entirely.
I would strongly agree with exactly what Mike has said. Obviously, I'm stressing it is really important to refer early, but you know, it's a team approach. Yeah, as the consultant, I want to know what's going on. Yeah, speak to us first, please. Jenny, I saw a question. What are the costs of prolonged dialysis versus transplant? The money question. So dialysis is really expensive. I can't remember the exact cost for a year of dialysis, but I think it's about £60,000. That's a rough guess, and my colleagues might disagree with that, but I think it's about 60 grand for a year of dialysis. And basically, the costs come from the nursing. You know, you're going to go to a dialysis unit, you've got a nurse there all the time, you're paying for them, you're paying for the dialysis unit itself, lots and lots of costs. I couldn't tell you exactly the cost of a transplant, but I know kind of after the first year, you're taking, you know, probably about 6 or 7 tablets a day, and I'm sure that's a lot less than 65 grand a year. So from a purely how much does it cost kind of scale, transplant is significant. Obviously, a little bit of an outlay at the start of the operation, but significantly cheaper. And then you have far less complications compared to dialysis. So, you know, someone on dialysis have much higher kind of cardiovascular risk. They have problems with access. They have problems with lots of things, really. It's, you know, a dialysis is whilst it is a life prolonging therapy, it's not brilliant by any means. And the complications of that will make it far more expensive than having a transplant that on average will last at least 15 years. And I've seen patients with transplants lasting 35, 40 years. So it is far more cost effective to give people a transplant.